Basic bowel elimination. Factors affecting bowel elimination can be age-related. Infants have really no voluntary control over their stools. Stools based on breastfeeding or artificial feeding or formula. Breastfeeding babies oftentimes will present with a yellow or golden color stool. It will be loose. It will not have much odor. If they're milk fed, it will be a little darker golden, but more brown, and it will be pastier in texture than loose. Diarrhea is considered if greater than 3 loose stools a day, except keep in mind those breastfed babies, they do have loose stools, non-odorous, golden color to kind of a light yellow. Constipation consists of dry, hard stools. Toddlers do develop the nerve control, the anal sphincter control at age 18 months to 24 months. Then voluntary defecation is possible. Parents need to anticipate and guide, and also regression is common, especially if toddlers are in the hospital. So if they're potty trained and end up in the hospital, you may find that they revert back and actually have some stooling in the hospital that's not predicted. So that's pretty normal given their age. Child and adult patterns may vary based on nutrition, fluid intake, and exercise habits. So older adults may have digestive changes like decreased salivation, decreased enzyme secretion. Also, don't forget about the mechanical kind of obstruction that can occur. Do their dentures fit? Do they know how to use them? Do they stay in? Do they have dentures? Constipation may be chronic because of GI motility decreasing and decreased fluid intake for older adults along with mobility. So it's important for them to increase their fiber intake, increase hydration, and try and stay as mobile as possible. Medications may have some impact as well. Fecal impaction is the buildup of stool resulting in chronic constipation. The first sign can be oozing liquids or even ribbon-like feces could indicate a fecal impaction. Diarrhea can occur from laxative or overuse of laxatives. That's why we like to stick to those bulk-forming laxatives rather than the stimulants. They can become dependent on the laxative, thereby resulting in chronic constipation. Fecal incontinence is due oftentimes to decreased muscle tone. Altered cognition can lead to that, and we always have to consider the skin when we're dealing with any kind of incontinence. Factors, we also need to consider food and fluid intake. High fiber is essential, so we need those legumes, fresh vegetables, fresh fruits. Water, 2,000 to 300 ml fluid intake a day is very good intake of fluid. Activity, we need to promote regular exercise. We need to support their lifestyles, their beliefs, their rituals, daily schedules, all affect regular patterns of bowel activity. Psychological variables stress may lead to diarrhea or constipation, and pathological conditions, stool changes may be clues to that. So we need to pay attention to our bowel habits. Factors affecting bowels medication-wise, cathartics and laxative promote peristalsis, which is basically peristalsis is that muscle contraction, those pulsating muscle contractions that help push stool through our intestines. So it promotes peristalsis. Antidiarrheal medications inhibit peristalsis. Remember, opioids, antacids can decrease GI motility, causing constipation. So if they're in the hospital getting a narcotic, they should always have some kind of bowel protocol. So we need to make sure we're on top of that. Medication side effects, of course, can be diarrhea, GI bleeding with any aspirin or anticoagulants. So we need to watch for any dark stools, which would indicate that the blood has been through the stomach. So that would be more of an upper GI bleed as opposed to bright red blood in their stool, which could indicate a lower GI bleed, so blood that has not been through the stomach. Iron supplements can cause really dark, black, smelly stools, so we need to consider that. Diagnostics, they may need to fast, they may need cathartics or enemas, so there may be a bowel protocol before their diagnostic tests. Surgeries and anesthesia can result in a paralytic ileus from a bowel manipulation. Can be temporary, 24 to 48 hours. Narcotics, again, decreased intestinal motility. And paralytic ileus. Symptoms include abdominal distension, absent bowel sounds, and an acute obstruction. Require surgical intervention. So, this is why we do not want to give patients anything to eat or drink after their surgery until bowel sounds have returned. So it's really important. That's one assessment that we cannot ignore. So please don't give, they're going to be thirsty, they're going to want something to eat or drink, but we need to wait until bowel sounds return before we do that because they could have a paralytic ileus. Nursing history, we need to know their elimination patterns, how often, time of day, their last BM, how much effort each BM would require, if they take anything that will help them go to the restroom. So we need to know all of that. Description of stool, so volume, color, odor, consistency, shape. You know, if they're getting these small little hard pellets as opposed to very loose, kind of explosive diarrhea. Any elimination aids used, recent changes in bowel patterns. So all of this is subjective data. So if somebody reports to you, every time I eat ice cream, I kind of have this need to go to the restroom really quickly, I barely make it, and kind of have explosive diarrhea, we would consider whether they were lactose sensitive or not. So were they lactose intolerant and not able to digest those sugars that exist in milk products? So we need to assess for that and kind of change their diet based on that so they can prevent that cramping and pain and diarrhea and gas that comes along with lactose intolerant patients. So our physical assessment, as you probably learned skills, is a little different. We do it in a different order. We inspect, and instead of percussing or palpating, we auscultate next. So we want to inspect and then auscultate, then percuss, then palpate. If we palpate before we auscultate, it may change the normal bowel sounds or the bowel sounds that the patient originally had. We do, if there's a problem with bowing, we do need to check the perirectal area, make sure that they don't have any hemorrhoids. Keep in mind that bright red blood that they may be producing may be from hemorrhoids as well. Common tests, CBC, a guaiac or a hemocult, stool, x-rays, upper GI, lower GI, MRI, colonoscopy. Make sure we know that colonoscopy prep, that go lightly, and then clear liquids 24 to 48 hours prior to that test. Diagnosis may include constipation, risk for constipation, diarrhea, bowel incontinence. So these are just some of the nursing diagnoses we may be able to use with these problems. Client outcomes are identified based on the problem identified. Nursing interventions are to facilitate the client meeting the outcomes of what our original diagnosis was. Promoting regular bowel habits, making sure we follow a pattern, making sure we're positioning properly and providing the most conducive way to take them to the restroom. So, you know, trying to avoid bedpans when we can get them up to the restroom as much as possible. Make sure that we're providing privacy. Make sure that we're paying attention to their nutrition with hydration and proper fiber intake, and trying to get them up and moving. This is particularly important after a surgery. Let's make sure that we're moving our patients to encourage motility and peristalsis. Constipation is the passage of dry, hard stools It's a slow transient time in the colon. That means all the water is getting really absorbed back into the system. So it leaves the stool very hard and dry. This causes great discomfort or pain or straining. We may really want to avoid this in some patients, especially post-op patients or post-MI patients, that extra strain on the heart, they really don't need that. These patients at risk are on bed rest. They have a lot of narcotics, decreased fiber intake. Maybe they're depressed, not moving around, not eating like they should, or pain. So that prevents, again, movement and proper hydration and fiber intake. Treatment of constipation, high fiber foods, increase fluid intake, exercise, respond to the urge when you have it, don't ignore it. Bulk forming are probably the most natural kind of laxatives to use. Stimulants we want to stay away from because those can cause a habitual use of laxative, and then we become dependent on them and cause chronic constipation. So the best kind is just to use that natural laxative or bulk forming laxatives. So diarrhea is another issue that we run into. We need to eliminate any cause that may be causing it, like medications. It could be a foodborne illness. So again, if they're lactose intolerant, you may need to prevent them from consuming those sugars that are in the milk that's causing the cramping and diarrhea. Assess for impaction. This may be a loose stool or a ribbon-like stool that's going around the impaction, so be aware of that. We always need to assess the skin integrity when we're dealing with dehydration, and the fact that they may become dehydrated. So a deficiency in fluid volume is always a problem with someone who is having frequent watery stools or diarrhea. Your patient too, obviously it's passing too quickly through the large intestine. Usually the large intestine absorbs about 800 to 1,000 mLs of liquid daily. When we're not getting that absorption, we actually have diarrhea. So it's passing way too quickly and we get soft, watery stool. So we know that that stool is not setting in the large intestine long enough for the water to be reabsorbed. So we need to return that GI tract to normal as quickly as possible. Probiotics help with that. We need to be aware again of C. diff, making sure that we are doing that hand hygiene with hot water and soap. The antibacterial liquid does not really help us with that. We need hot water and soap. Again, teaching safe handling of food. Chronic diarrhea is greater than 3 to 4 weeks. Need to evaluate the underlying cause and then get our anti-diarrheal medication for that patient. An absorbent, we can use Pepto-Bismol, especially for traveler's diarrhea, or kaopectate, which is more of a absorbent, or Imodium or Lamodal. These act on the GI smooth muscle to impact peristalsis. So all of these medications will help us with diarrhea. Incontinence of bowel, the inability to control the sphincter. Causes can be disease, underlying issues, overuse of laxatives. This can be very embarrassing, can cause depression in patients. Of course, risk for skin breakdown, dehydration. Bowel training programs may be necessary with client. You need to support and teach them, encourage fluid intake, incorporate an exercise program, make sure they have privacy, make sure they understand how to administer a suppository when and how it's appropriate, or any other laxative, and evaluate and modify their program as needed.